Good morning, Antonio.
Hello. Antonio, he said Diego.
Yes.
Oscar,
Hello.
very nice to see you. With the mask, we don't recognize everybody, but
Yeah, but
okay.
I can recognize your voice and Giuseppe. So thank you so much for the invitation.
Oscar, I am impressed how your gloves and the operation field is clean. And not a single, it's the first time I don't see not a single drop blood.
Also, we have a lot of audience here and panelists, commentators. Antonio and Gibbs with us since yesterday, and he's doing a great job. We're speaking. This is a TAVI session, as you hear. This is the live. We asked Oscar to have a special for you, all of you, and thank you very much for your cooperation on the CV rep. And we hope to see you physically for the silver jubilee of Cardio. Alex, you mean that in next June? You promised me, okay?
Yeah. We'll do my best. I'm sorry for not being with all of you there. I love to go and to meet so many friends for so many years. I've been visiting you, and thank you for the invitation. And this year is going to be in this way, live. So if you allows us, I will introduce a 40 seconds video from Buenos Aires to invite to all of you to here to visit us, and then the slide to present the case. Is that okay?
Go ahead. Yeah.
Hopefully you can hear the tango song. Let's go. La primera diapositiva. 1 second, please. Just to let you know, this software that we are using today, it was developed for our engineering here in Favaloro Foundation Hospital.
We don't see anything here.
Now?
Okay, go ahead.
Yeah.
No, it's okay. Favaloro cardiovascular system.
Acercarle el micrófono y dale volumen
There's
alto.
no sound. Yeah. Tango, huh? I think tango. Oscar, we don't hear sound of your film. I think it should have sound. Can you repeat again? Because I need to hear that.
Yeah, unfortunately, we have a technical issue for the sound.
Okay, go ahead.
Okay. La próxima. Okay. So sorry for the sound. Next time we will do it better. The issue is Professor Sogui might ask to present the TAVI case with the coronary artery disease. Let me introduce first the team. This is Carlos Favato on my side, our fellow, Maru, our tech, Matias, the anesthesiologist, Dr. Jaime, Josefina in ECHO. The TDS from Medtronic is the higher level tech from Medtronic here is Victor, and Mr. Bulacio is handling all the cameras in the lab. So vamos a los slides de nuevo. So this is a 78-year-old male with a history of hypertension, dyslipidemia, and obesity. He has suffered a deep venous thrombosis after a car accident, and he also suffered from COPD. He presented with dyspnea. The echocardiogram showed preserved left ventricular ejection fraction with severe aortic stenosis, with some mild pulmonary hypertension. This is the medical treatment. He was under anticoagulation, beta blockers, nalapril and atorvastatin. Next. This is the ACG in the morning, left anterior fascicular block. The PQ is borderline 200 to 10, but this is the reason why we decided to put the wire on the right ventricle for the live case. Next. These are the echo. You see significant calcification in the mitral annulus, but not gradient, not significant insufficiency, but severe left ventricular hypertrophy. Next. This is a bilateral or biatrial dilatation, preserved diameter of the left ventricle with severe septum hypertrophy with some middle ventricle gradient, which is going to be probably residual after the TAVI case. And we can comment after the procedure. Next. This is the gradient on the aortic valve. 97, the peak, median, the 60 with an area of 0.9. Next. These are the coronary arteries, small right, next, next. And as you can see, it's a dominant left circumflex with some diffuse disease, but not significant lesions. But you can observe a very tight proximal lesion on the NAD. Next. Here in the spider view, you can see a little bit better. Next. This is the CT scan and the pre-TAVI evaluation. The mean diameter is 23, the perimeter of 75, the area of 438. LVOT is quite similar, so not too much, not too bigger, but with, as you can observe on the right of the panel, there is LVOT calcification. Next. This is the tricuspid valve with significant calcification, and this is the reason why we had decided to pre-dilate in this case. The sinus of a valve average of 33. Next. And this is the height of the coronary arteries, left and right, which are okay, about the 10, actually about the 15. Next. This is the cusp overlap view, right anterior oblique of 7 degrees with a caudal inclination of 29. And this is a significant angulation of the aorta is 54, as you can observe there. So it's going to be probably the most challenging part of the case. Next. And vascular access are okay. Big arteries, no significant calcification. The ascending aorta is also okay. Next. So it's a low-risk patient according to the STS and Euro score, but he's old and with COPD. Next, and this is the reason why the heart team next sent this patient for TAVI instead of cardiovascular replacement. I mean by surgery. Next. So this is the oversizing. We have selected the 29 valve. It's going to be oversizing of probably 26, a little bit too much because the perimeter is borderline. Remember, it's for 29 is between 72 and 82. But anyway, the sinus of Valsalvas are quite big, 33. That's why we decided to go with the 29. Next. Next. So in summary, it's a male, 78, almost octogenarian with severe aortic stenosis, coronary artery disease, low risk by a score, but with COPD. The heart team suggested PCI and then TAVI. Next, this is according to the guidelines, the European guidelines which were updated. PCI is class 2 with a level of evidence B. In the American guideline is 2A. Next. Next. According to the Notion trial, probably the indication of PCI is the correct option for this patient before the procedure. Next. This is what Dr. Fava did, who is on my side, pre-dilatation and then the short stent, 3.5 by 33 millimeters. Next, excuse me, by 13 millimeters. This is the final angio, which was quite good. Was not done IVUS, probably should have been done, but it was not done because some economic issues, as Antonio mentioned before during the presentation. But we have a very significant test that this stent is perfect because the patient stopped clopidogrel after 5 days. So nobody knows why he is not taking clopidogrel for almost 10 days. He was confused about the indication or something went wrong, probably our responsibility. But the fact is no thrombosis, the patient is perfect. So we will correct that after that. Next. So let me show you what we have done and then we can discuss. So we did a puncture. We always try to find for the fellows. I know that you have a lot of fellows there. Yes, yes, yes.
Oscar, you hear me?
Yes, perfect.
Can we discuss
Yeah.
nowadays the guidelines or your practice? Are you doing angioplasty before the TAVI, or the days before, or in the same procedure, or after the TAVI?
So, hello, Oscar. It's
Hello,
Giuseppe
Giuseppe.
Tanti.
Yes. Hello.
Hi. So, the timing of PCI, it's highly related to two factors. One is the reason why the patient has been admitted in a hospital. If the patient has been admitted in a hospital because of ACS, you have 90% lesion like this, I think it's better to start with the coronary artery. Related to the timing, it depends also on the valve type that you want to implant in the patient. When I decided to go with the tall frame, I prefer to treat the coronary before and then to go with the valve in with the coronary alignments. Otherwise, if you decide to go with a short frame, actually you can start also with a valve and then to recannulate and to go for PCI. This is at least my practice.
Okay.
Yeah,
Antonio.
Antonio.
We most of the time, Antonio, we most of the time do as you did. We do it before PCI, and then at the time we do the valve. In some circumstances, for logistic reasons, if the patient comes from far away, we do both at the same session. But most of the time we do before and then after.
For the
If the patient
for the proximal lesions. I mean, if they have proximal lesions, not speaking about distal, mid, distal.
But in the new ESC guidelines, the real 2A indication is for lesion more than 90% proximal. It is no more 70. 70 is 2B level of evidence B.
and the same goes for left main?
No?
The same for
Proximal lesion more than, the left main is,
So you will defer left
go,
main stenting.
goes by itself. That when you have a tight lesion, a left main,
No.
you need to treat first.
You may defer left main stenting to be done after TAVR?
If I have an ACS syndrome, I will start always with coronary.
Yeah.
If I have a left main or very severe proximal AD, I start with coronary again.
Okay.
So this is what I do.
Okay. Oscar, go ahead.
Okay, we also we usually do before because we are treating very old patients here. Although some of them have low risk according to the score, most of them are very old, and so we find a lot of non-dilative lesions. So we have to deal with rotablade or lithotripsy, something that we don't like to do in the same procedure as TAVI. Probably some
in the case we don't put a tall frame valve. In case we have to do calcium modification or things like that, rotablation, etc., we prefer to go with a short frame valve.
Yeah.
Because we fix first the aortic stenosis, then we cannulate, staying below the coronary, take off, and then we move, without the hemodynamic impairment or aortic stenosis.
Yeah, we agree with you. Last day we did a patient with the left main stenting implanted 6 years before. It was okay, the stent, but we decided to go with the balloon expandable valve because of the short frame and the possibility to get back because this is a 76 or something patient. So it's probably this patient is going to be lesions in the future and we will need to get back to the coronary arteries. But in this case, we have chosen a self-expandable valve. We are using Evolut FX, which is recently introduced in Argentina, probably with some delay compared with Europe. Let me show you what we have already done. So we did the echo and angio-guided puncture bilateral. Next, let's go quick. So this is the puncture. We always test where we are. We rather like to go a little bit high. We did one ProGlide first, and we put an 11 French on the groin while we were waiting. So, and 3 or 4 minutes before going live, we introduced the 14 French sheath. With this camera, you can show my hand here. Voy a mostrar la mano mía izquierda con la cámara de los pies. Gustavo. And then we cross the valve. As you can see, we use always the pigtail and the J-wire. Remember, the stenosis is not a fusion like you were talking before. It's a rheumatic fever. It's a completely different story. In this case, you probably need, in all the cases, the AL and the straight wire. But you can see it was very easy, less than 1 minute to cross. And where we are here, we test the valve before to be ready. The idea is to pre-dilate. Hope you agree with me with this calcification. How many of you would use pre-dilatation? And now
We used to go almost always with pre-dilatation with the door frame valve.
Okay, that's great. And as you can observe here on the
Which balloon do you use in this case?
20. You can observe here that we have significant calcification. I think pre-dilatation is going to be okay.
I think the discussion of the size of the balloon is important because you have decided for a 29, isn't it?
Yes.
29. So 29 means the level of the waist. The level of the waist is about 23, correct? Is about 22, 23. So when you go with a 22 millimeter balloons, for instance, you can go for pre-dilatation and also post-dilatation. But actually is different compared to the other valve because when you use a 27, 29 valve with a Navitor or other valve, you need to go with a 25 balloon for post-dilatation because there is no restriction at the level of the waist. So this is one thing. So we used to, in our practice, we prefer to go with a 22 millimeter balloon or 23, a little bit less inflated, to use the same balloon for post-dilatation. This is just to discuss this point for this type of valve.
Yeah. That's a good suggestion. It's important for us to use only one balloon, but unfortunately we have already opened the 20.
Oscar, did you use the pigtail to cross the aortic valve?
Yes, in about 80% of the cases. We needed
which wire do you use?
Regular J-wire. Looped. In most of the cases, you can see on YouTube, we have many cases. And there is somebody from Egypt who was here in the hospital visiting us. And you have to take the time, sometimes no more than 1 or 2 minutes. But in most of the cases, you will do it. If you point to the center of the aorta, you will cross it.
And if you don't
cross, we did the same many years ago. We did the same also.
If you don't cross but not now. With the regular wire and the pigtail, what's your next step?
With the pigtail, the next step is leaving the pigtail there.
If you can't
if you cannot cross, go I go with the Amplatz catheter and straight wire. Yeah, not hydrophilic, the regular straight wire.
Not hydrophilic.
No.
Also, you will use Amplatz with regular wire.
With regular wire, but straight, not J.
But it's not trim wire.
Straight.
Not trim wire.
Those trim wires. You don't use hydrophilic wires.
No. Never, ever.
Okay. Never.
I don't like
my
it.
My question also to you about, also to Gipsy and Antonio, about the pacemaker. We are using nowadays the over-the-wire, but in some cases, it doesn't work. So you need to have a pacemaker, or a regular pacemaker. So do you have cases which you don't accept to have over-the-wire pacing?
Yeah, in some we also use pacing on the wire for most of the cases, except those with the predictor of blockage, like right bundle branch block, prolonged PQ, something like in this patient. And if we are live and we have some predictor, we would rather like to have the wire on the right ventricle. If not, we pacing over the wire, leaving a wire in the vein just in case of emergency. And when we have the pace like here, we tested before to be sure we have a good capture. And we are pacing with the wire, we have to wait to introduce the balloon for testing Let me show you something else.
Question.
Yeah.
Question
for
you, Oscar.
You can work while I was asking.
The ECG showed a bifascicular block. So there is definitely a higher incidence of AV block.
Yeah.
So would this push you to use a balloon expandable stent instead of the long struts? And you know the risk is much more than in hard blocks.
Yeah, I know. We are trying to review our data. Actually, we were discussing yesterday. The feeling we have is that predictors are more important than the valve. Although we're implanting the balloon expandable valve in the cast overlap view to implant this valve also high. But when you have significant predictors, the pacing rate is still high. Let me show you something. We are going to use the confida wire. This is a very small ventricle. I have reshaped it to decrease the loop of the tip of the wire. And then, let me show you, I introduce a second vent here to facilitate, especially in very angulated aorta, to retrieve the nose cone. So if you agree, we proceed with the predilatation and the valve implantation, while you can comment or discuss.
Going back to the comment of Antonio Colombo, it seems a bench test. There is no single drop of blood.
Let me tell you what we have done. We have some drop. We
You
have
a different layer. You have done
yeah.
layer.
We have the regular cover here. We use sterile drape for the skin. We are not touching the skin. Mostrame la mano aquí. Aquí.
He did most of the cases offline.
Yeah. And then all the punctures were done offline, and then we change it.
Or maybe it's a blue-blooded patient.
Sorry?
Maybe it's a blue-blooded patient.
Yeah, and the patient is under conscious sedation.
So I would imagine that you go for commissural alignment.
Yes, I will do it. Or I will try.
If we have time, in during the talk, the previous talk, the audience asked to go for selective coronary cannulation at the end of valve positioning. If we have time, do you mind to go for selective cannulation?
We can do.
The left and the right.
I will try. So as you can observe here, the ventricle is very small. ¿Hicimos la proyección, la inyección? No, let's go to the projection first to do the angio. It's derecha 7, caudal 29. Okay. Okay. Okay, let me position it, the catheter a little bit better. Okay, the overlapping is very good. The angulation is significant, as you can observe. So let's go with the predilatation. Okay, marcapasos 180, 180. Let's see it. Vale, Carlitos. Okay, go. It's okay. Deflate. Bájalo. Stop. Teneme. Stop. No, deflate. Okay. Okay, we'll try not to scatter a lot of blood because Antonio is going to be upset. So now we are going to the valve. The special characteristic of this in comparison with the Evolute, the previous Evolute, is the nose cone is tapered, as you can see here. Zoom, Ancaña. Zoom. Okay, you can see it's longer and tapered in comparison with the previous one. Then the valve has only one spine, so probably the navigation is going to be better. The distal part of the stability layer is longer, so probably it's going to adapt a little bit better for aortic angulation. This is the description from Medtronic. Let's go to the oblique izquierda. So here, following Giuseppe observations, you see the cap is on the external curvature of the aorta. So do you agree, Giuseppe?
Yes, I agree.
Okay, there. And now,
Let's do the arch. Let's do the arch, and then I think it's possible to see it better.
okay, soltalo.
Is this a FX Plus, Pro Plus? What is this valve?
Is this FX plus? FX,
Plus.
no, FX. We still don't have,
FX is
yeah.
not a Pro Plus.
Yeah.
So we don't have the market bid at the end. So
No.
this is the point. Okay. So we need to look at the head market. Here is possible to see that we have
Zoom.
the outer curve.
And now
Then
the cap,
what we can do is to make a double check in the cusp overlap view. If
Vamos a
the
la-
hat, the marker
a la
hat
derecha.
is at the center front, it means that the valve is well oriented.
So you look first in the LAO at the
It
descending aorta.
looks good.
sacale
You start
caudal.
with the descent, looking at in the LAO.
LAO,
descending
you
aorta.
start LAO, the
Esa
hat
es la-
markers
la
need to
proyección.
stay to the outer curve. Then you go cusp
poquito más,
overlap.
7.
When you see center front, it's okay.
Sacale
And
la
then
caudal.
we also while the valve is. This is the way
Okay.
we go with this valve. With the FX Plus,
Eleva
you
la
have the
mesa un
market
poco.
bid. You have two market bid in the cusp overlap on the right-hand side of the screen, and this is.
Okay, ahora
you have
caudal.
almost.
Levanta la mesa un poco. Levantala. Okay, now. Do you agree there? Test? Okay, we will start there. Cuando te aviso, le ponemos 140, ¿sí? Dale, Carlos.
So the pigtail seems to be a little bit
A little
shallow,
bit,
but
Stop, para. Test.
yeah, test. Yeah, it's
Okay,
okay. the valve is
140.
okay. Yeah.
140. Dale.
So in your practice, why you deliver the valve? What we do is to go exactly with the pace 120, just to stabilize the to and fro movement of the valve.
No.
And you can
Okay.
go
Baja el
fast in
marcapasos.
this part. The first phase you can go fast, and then you go slow at the very end
Okay,
to
so
avoid
let
to
me
have
test.
surprise.
I think the position is okay. Let's go to.
No, you have the markers here. This is the FX Plus. You have the three
Yeah.
markers
Yeah,
there.
there are 3 markers. That
Yeah. Seen it? I think the position is okay. What do you think?
It's almost ground zero. It depends on you if you feel confident. What I do in this case is to pull a little bit back the wire, pushing the valve, just to be sure to not have the nose cone when you deliver the valve, that anchor on the valve, you have a pop-up of the valve. Just pull the wire to change the direction of the nose cone and push a little bit the valve. This is what I do usually, but it's up
Seen
to
it?
you.
I think it's too shallow.
Is
Yeah.
it possible to check the image?
It's
with the
too
customer
shallow,
view?
but
Yeah.
pull the wire a little bit. Pull
No,
the wire
it's,
just
I-
to
No, I don't want to pull a little
to
bit more
raise- to
because
raise the nose
I don't.
cone.
I don't want to lose the loop of the wire because the ventricle is too small. I will recapture.
Yes,
I will go a little bit lower.
Did you go in cusp overlap?
Yes.
Did you try in cusp overlap?
Yeah. 140, recapturamos. Dale. 140. Okay. Test. Okay. Now it's better. Ahí, dale.
It's
Sí,
a little
sí.
bit deeper,
Test.
a little bit deeper. Otherwise, you will finish up at the same plane.
Okay. Stop pacing. Seen it? Now it's better. Let's go to the left.
Yeah. Can you try also in cusp overlap to make the angio?
The
Cusp
previous
overlap.
one. The previous one was cusp overlap.
Okay. Let's do also in three cusp.
Vamos a la izquierda.
Seems-
Vamos a la izquierda.
Can we just do some modifications
Could
in
you
the top
put in
of
the
that,
same
that
line the
field of
three
Favaloro?
markers?
Yeah. Inject.
Same line of the three markers. Yeah. Okay?
Here I like it more.
It's too shallow. It's too shallow. For me, it's too shallow.
Okay, we will do one more. Vamos a la oblicua derecha.
It's too shallow. I would go in this projection, Oscar.
Not sure.
Just reposition the value in this projection.
140. Let me do
Because
one
it's
more
the one
here.
that is-
Yeah. Dale. 140.
Very high, but it's not bad. It's,
Salta, abbiamo finito. Chiudo coronato.
Test. Cerrarla toda. Ok, vamos de vuelta ahí. Dale. Test. Dale ahí. Test.
If you start deeper, when you open up the flower, then you can pull the valve and change also the parallaxis. And this can improve the final orientation.
Ok. Stop. Vamos a la izquierda.
Not too bad now. So
Cine.
again, keep pushing the valve, keep pushing the valve. Now,
No, I think now it's okay. What do you
I think
think?
it's okay.
be acceptable.
Yeah.
Yeah.
Might be acceptable. My suggestion is to pull the wire to take the nose cone at the middle portion of the valve. Otherwise, when you deliver
Facing.
the valve, the risk is to grab the valve and to go up.
Dale. Ujú. Inyecta.
I would pull the valve. I would pull the wire.
Dale.
The delivery is too aligned.
Okay. Well, now is when I use this second vent to retrieve the nose cone. That unfortunately I lose it. Okay. Let me do an ancho.
Touch anymore.
Ponía la oblicua derecha.
Just me.
Okay, let me inject and then we will do it. The position, I like it, but we have a significant leak. I think we had to post dilate.
No, the only things, only in my concern, the position is absolutely not too bad. My concern is that when you go for the second inflation, you need to keep the balloon very stable. Otherwise, with the post dilatation, the risk is to have a pop-up of the valve.
Dame un 23.
And for sure, I won't go with the 20. I won't go with the 20 millimeter because
23.
it's going to be to and fro. It's risky.
Yeah.
Yeah, 23 is better, and be careful to not go too deep with the balloon.
Oscar, why
Yeah.
did you do the second bend in the stiff wire before entering it?
The second bend is when you have a significant angulated aorta. When you pull the wire, this second bend usually elevate the nose cone to the center of the valve. So sometimes it's much easier to retrieve, especially when you are shallow, and also very special when you have significant notch of calcium in the non-coronary cusp. Vamos.
So it helped you to only to retrieve the nose cone, not on the
Yeah.
of the valve.
Yeah. No, only I think it's the wire is not stiff enough to modify the entrance of the valve. Bueno, ahora le vamos a dar a 200, y necesitamos no infle hasta que la presión no está bien baja.
Un poquito más de
Ujú. Agua.
agüita.
Dame un segundo. The balloon should be very well diluted to inflate and deflate very fast. So, okay, 200. 200. Dale, Carlito, rápido. Okay. ¿Todo? Stop, parar el marcapaso, stop pacing. Let me review. Probably I diluted the contrast. Probably the dilution was too much. Let me check. And then let me check with the echo. Significant better. Can we check with the echo? Put the, I will centralize the wire and we'll check with echo. Hopefully you can see the echo. We will put 25 here to make a good orthography after the echo. So the configuration of the frame of the valve, in my opinion, is a little bit better. The ancho was better, but let me check if I am right or wrong. So the patient is with COPD, obese. It's not that easy, the TTE. Are you observing the echo? No, pero mostrame
Yes,
la
we see
insuficiencia y la estenosis.
We see the echo.
Yeah.
When you still have aortic regurgitation significant after doing a balloon dilatation, are you going to justify to put another valve inside the valve?
No, only in cases we have a too deep implantation of the valve. But if it is a problem of the dilatation of the valve frame, not the shape, the configuration shape of the valve, we can use 23 again, or probably 24 or 25. So, what is your opinion about the echo?
With a bigger size.
Yeah, tenemos. I will put the pigtail. I will not retrieve the wire, just in case. And we will
Any commented? Dr. Ahmed, Dr. Magid.
As regarding your question about the management of
post balloon dilatation with the balloon was very low. I know that he's afraid that the valve will pop up, but I think it's very low. I don't know if this is satisfactory or not. The post balloon dilatation.
Dr. Ahmed.
Depend على what degree of aortic regurg, and if most of the aortic regurg is central from the wire. So I think he would need good
sometimes the wire
assessment.
will produce aortic regurgitation.
Yes.
So at the end, Ramid,
So, decime qué es lo que estás observando.
Nothing specific. I mean, I'm more familiar with the Edwards, but
Can we see the final
I
angio?
think they,
Yes.
treated the regurgitation very
According to echo, it's a
15, 30.
minimal.
How much is the
well. The
angio?
balloon, but again, I mean,
It's
the
a
balloon-
minimal leak. Podemos.
Okay, can we see?
Minimal anterior leak.
Clean
Let me
the
do
well conduct.
Let me do 0, and I will show you the pressures, the monitor, hemodynamics. Pone eso en una pantalla grande. Do you see? In my opinion, it's okay. I will do the angio. A very nice notch in the aorta. The diastolic is it's okay. Let me check there. Búscame un diagnóstico de izquierda y uno de derecha. Ajá. One second, we have a problem here. No, in my opinion, I don't know, Giuseppe, if you agree, but I think we have a very good.
Yeah, it's perfect. The result is perfect. Yeah. Result is perfect. I think you deserve applause.
Are you going to do selective angiography according to that advice?
If we have time, we can try. I don't know how is the time.
You have 3 minutes.
Let me try.
3 minutes even for the left.
Oh, let's go for the. Dame de la izquierda. Let's try with the.
What is the rationale behind doing a selective angiography after putting the valve? You will do nothing. If the valve is malaligned, you will do nothing.
I will not do it.
I will not do it, yeah, but
No,
the
don't
question of the
do
audience, is there routine or not? Okay.
Sometimes
Okay,
we do
I
it
think
with
it's okay, Oscar.
Yeah? So,
He's
Do
doing
it.
it.
Do it off camera.
He's doing it.
Okay, you have only 3 minutes. You have.
Gonna be less.
Any question from the audience here to this wonderful case? He's going to do it. خلاص أدخلها له مش ينفع.
We can close it.
I think we can close.
It's easy. Easy case. It's not easy. It's not easy. It's like it.
Nice demonstration.
It's not.
Okay,
Perfect.
good.
Okay, Oscar, thank you very much. I think this is a wonderful case. Good interactive discussion.
Dr. Oscar, one final question. You used only one proglide for pre-closure?
Only one.
Only one proglide?
Yeah.
Is this your routine practice? You use only one
Mostrar.
proglide?
Okay, this is the angio. We only use one proglide, and in most of the cases we finish with the one angio seal. We close it over a 6 French introducer.
So he has an angio seal.
Okay.
Yeah.
One proglide and maybe one angio seal.
One proglide. Mostrar acá.
Proglide. We used to do 2 proglides, now we use proglide angioceal.
Yeah.
For us, we don't have a. So already we have two proglides.
Comprimí.
What's your strategy?
Revertimos. No podemos revertir. Something important. This is a coronary patient.
We use Manta. Also Manta.
Oh, in spite of the fact that Manta now is.
It's 14 French, not 8.
Professor Sohvi, something important. We usually revert the heparinization, but not in this case, which is a coronary case. Very recent stent.
Okay.
Dame luz arriba.
Okay, thank you very much, Oscar. We come to the end. I think it's a wonderful case, illustrative how to make it to the coronary plus TAVR, because we asked you to have this. We have one before for just about acute coronary syndrome. With TAVR, now we have a challenging when to do it. Thank you very much, and see you.
Thank you all for the invitation, your comments, and your help. Thank you so much. See you soon. Dame el ancho seal.
Ahmed Al-Amrawi. Tony Colombo. Oh, TAVI complications.
About coronary obstruction, and this is a case which occurred relatively recent. I try to advance. Oh, it's not advancing. Okay. So it's an 81 standard risk factor endocarditis. He had a surgical valve, freedom solo, and mitral valve in 23, admitted for dyspnea, progressive increase in transvalvular gradient. So basically is a valve-in-valve in a patient previously treated with a surgical valve implantation. He had a significant gradient, 67-103, a small aortic valve area. That everything else is unremarkable. Coronary angiogram, no significant coronary disease. Blood work okay. Age reduced, so obviously is a clear indication for
No sacó foto.
transcatheter valve. So
Bien, bien, bien.
this is
Ahora le pedimos allá.
the measurements. The area is
No,
425, sinotubular junction 27, VTC 34, so relatively small. Corner height, right corner is 6.3, left corner is 6.6. So is the sutures left, radiopaque. So I'll stop here about what to do.